Hi, let's talk about colorectal cancer. This exemplar falls under the concept of cellular regulation. Cellular regulation is the idea that the cell is the basic structure of every human body. Cells form organs, which form organ systems, and then organisms. And every cell has a specialized purpose in the body. With cancer, there's a mutation, and that those cells lose their specialized purposes, and they no longer mimic their parent cell, and they just begin to spread, and it can cause a lot of problems. So colorectal cancer, the cell origin cells are the glandular cells, and the problem is that it can then metastasize to other organs. So this TNM classification can be used for cancer. It's also used for other cancers. The T would stand for the tumor and how large that tumor is. So the higher the number, the larger the tumor. N stands for node, and that is the number of lymph nodes that are involved, which makes it riskier for then metastasizing to other organs. And then the M stands for that metastasis and how many organs that has metastasized to. So you may see that in a chart, and it might look like T1, N0, M0. So it's helpful to know what that means. Some risk factors, there's quite a few. If there's a strong family history of this, then it's more common for that person to, develop it themselves. Inflammatory bowel disease, so this would be Crohn's and ulcerative colitis, which we'll talk about this semester. Physical inactivity and obesity, those kind of tie in together. Diets that are high in red meat and low in fiber. Fiber helps clean out those cancer-causing toxins. So if somebody doesn't have a lot of fiber in their diet, that's just building up, and over time that can cause a mutation. History of diabetes, smoking, alcohol use. The incidence does increase with age, and then pollution. There's not a lot of clinical manifestations with colorectal cancer, which is why unfortunately it's one of those cancers that's usually diagnosed when it's already pretty far along, sometimes even after it's metastasized. So there may be some pain, although that's uncommon. The change in bowel habits is probably the most noticeable change, and that's usually constipation. The person may become anemic or have a GI bleed, and then fatigue. So like I said, those are pretty benign symptoms, and you might not even notice that that's happening until it's pretty far along. So this is diagnosed a couple ways. They may initially see something on a CT or an MRI. They may notice that anemia on the laboratory tests, along with some other labs that we can do. The definitive diagnosis would come from a biopsy, which we would get through the colonoscopy. So they may see, and this may be through a routine colonoscopy. They may see that and then get a biopsy and know that this person now has cancer. So treatment would include chemo and radiation. We can also do surgical management, where we may do a colectomy, which means removal of the entire colon. That person's definitely going to end up with an ostomy in that situation, which is a major lifestyle change. So if you need to go back and review ostomy care, that's something you went over in UR 170. They may do a hemicolectomy or a resection, so that's just removing portions of bowel. Sometimes they can reattach those. Sometimes they may have a temporary colostomy and then go back to surgery and they reattach those. So we're always trying to preserve as much bowel as possible when we're doing these surgeries, because you need that bowel tissue for absorption of nutrients, but also for absorption of water, especially in that large intestine. That's where a lot of water absorption happens. If you do a complete colectomy, that person's going to end up then with an ileostomy, and they can lose up to 1 liter of fluid a day through that ostomy. So then they're going to be at risk for fluid volume deficit, probably for the rest of their life if they're not getting enough fluid. So when you think about ostomy care, ostomy teaching, the pain that's involved just with surgery and chemo and radiation, and then disturbed body image. I mean, this can happen sometimes to a young person, but even an older person, ostomy is just a lot to deal with. So Don't be surprised if you see a lot of those stages of grieving when it comes to this, where they may go through denial, where they're refusing to take care of that ostomy. All of that is pretty typical and common for what you'll see, so try to remain empathetic through this whole process. Our big worry is going to be metastasis. Once this metastasizes to other organs, it's very difficult to treat. We need to think about infection, especially if they've had this bowel resection or colectomy, hemicolectomy. You need a wound to heal that's constantly draining feces, that's not sterile. So there's a big risk for infection with that. If they're having GI bleeds, or even just the effects of chemotherapy can cause an anemia, fluid volume deficit, especially with that hemicolectomy, and then impaired nutrition. And this may be lifelong if they've lost a lot of bowel tissue, or there's a lot of scarring in the bowel, then getting the proper nutrition is going to be difficult, and they may need to be on supplements. So again, do your reading. This is just a very brief overview of colorectal cancer. Make sure you come to class prepared and ready to do some activities. So I'll see you there.